Welcome to the Johns Hopkins Women's Health Podcast, A Woman's Journey, Insights That Matter. I'm Kelly Gear-Ripken, and I invite you to listen to Johns Hopkins specialists discuss the latest topics in women's health. Now here's your host, Lily Shockney.
Hi, this is Professor Lily Shockney from A Woman's Journey at Johns Hopkins, and this is our podcast, Healthy Insights That Matter. According to the Alzheimer's Association, more than 6 million Americans of all ages have Alzheimer's disease, nearly 3/4 of whom are age 75 or older. This means that about 1 in 9 people who are age 65 and older have Alzheimer's. Almost 2/3 of Americans with Alzheimer's are women. In this month's podcast, the first of our new year, I am going to be joined by Dr. Halima Amjad, an assistant professor of medicine at the Johns Hopkins University School of Medicine, whose clinical expertise and also research focuses on individuals living with various forms of Alzheimer's and dementia. So welcome, Dr. Amjad, and thank you so much for joining me today.
Thank you for having me.
As I mentioned at the beginning of my introduction, reveals an interesting fact that almost 2/3 of Americans with Alzheimer's are women. Why is that?
So when it comes to Alzheimer's disease and dementia, I'll say we're still learning a lot, and there's still a lot that we don't know. And why Alzheimer's disease and dementias are more common in women is one of those areas. But there's a couple of theories and thoughts about why this is the case. So one is that actually age is the biggest risk factor for dementia, and women live longer, but that doesn't entirely explain the differences that we see between men and women. So a lot of research has been looking at why else might this difference be present. So there's some studies looking at, for example, are there biological factors that might be the difference? So differences in brain structure and functional connections, or what some scientists will call brain architecture. There's interest in hormones, particularly estrogen, and whether that might affect brain function over time. There's also research into genetics and looking at sex-specific genes. So again, can that explain the difference? And then even beyond just the biology, the genetics, there's also research looking at social and cultural factors. So, for example, we know that levels of education and work history earlier in life can affect the risk of dementia later in life. And especially, I think, now there's generational change, but we know that in the current older generations, women may not have had the same educational and work experiences that men did.
Is it thought that for female hormones, that it's the reduction of the female hormones in our body, menopause basically, that might be contributing to this problem for women?
That's definitely been one of the thoughts, that there's estrogen receptors in the brain. Estrogen can have an effect on certain neurotransmitters, so sort of quote unquote brain hormones, as well as direct effect on neurons, so the brain cells. But I will say, right, then the thought would be, okay, maybe we need more hormones, especially postmenopausally, but there's not actually clear clinical evidence. There have been studies looking at the effects of hormone replacement on cognitive decline and dementia, but we really don't have clear clinical evidence yet that that's the solution, that that's fully the answer in women, that replacing those hormones reduces the risk of dementia, but it's an ongoing area of research.
I understand that Alzheimer's disease is one type of dementia. What separates Alzheimer's from other forms of dementia?
So that question, I would say, brings up one of the most common questions that I get in clinic, right? What is Alzheimer's disease? What is dementia? What do I have? And dementia really is just an umbrella term for a number of different diseases. And dementia refers to really cognitive changes, memory, language, complex thinking that starts to affect functional abilities. So being able to just complete regular complex tasks that a lot of us do every day, driving, using a computer, managing medications and appointments, just this cognitive change that makes functioning in your daily life harder. And Alzheimer's disease is one cause of dementia, and it is the most common cause, but there's other diseases that we commonly see as causes of dementia. So there's something called vascular dementia, Lewy body dementia, and frontotemporal dementia, and many more. And we actually think that mixed dementia, so having more than one cause to explain what's happening, is actually second only to Alzheimer's. Now, you would ask what separates Alzheimer's disease from the other types of dementias, and there's a couple of things. So one is the pathological difference. What's happening? What's causing the disease at a microscopic level? Sometimes it's what areas of the brain are affected first, and all of that can affect clinical differences, meaning differences in the symptoms that we see in the person who has dementia, especially early on. To give a couple of examples for those most common types of dementia. So Alzheimer's disease is classically caused by amyloid plaques and tau protein tangles that are affecting the brain. And it most typically affects the memory centers or the hippocampus of the brain first. So what people often see are trouble with short-term memory, forgetting something, losing things in the house. That's different from some of the other causes of dementia. So vascular dementia is sometimes caused by a big obvious stroke. Sometimes it's caused by small, almost imperceptible strokes that over time lead to damaged brain tissue and can affect, cognitive abilities. With vascular dementia, you can see almost any symptom depending on where those strokes occurred. But often we see just someone says, I'm thinking more slowly, or family members say that the person's responding more slowly, taking more time to complete tasks, or seems more confused. And then the other two types of dementias I mentioned, so Lewy body dementia, there's a different protein that's implicated called alpha-synuclein protein. And with that, in addition to the cognitive changes, you can see symptoms that look like Parkinson's, so tremors, slow movements. There can be sleep disorders and hallucinations, so a different constellation of symptoms. And then the last most common type of dementia that we see is called frontotemporal dementia. And that can come with a couple of protein abnormalities, like tau protein, which we also see in Alzheimer's, and two other types of proteins that scientists have been able to name over the past couple of decades, TDP43 and progranulin proteins, for example. And those affect the language and behavior centers of the brain first. So the behavioral variant families see really drastic changes in personality or behavior in the person who has the disease. In the language subtypes of frontotemporal dementia, people have just trouble either producing words or they're using the wrong words. It's the symptoms that can look different, especially early on. So what's causing the dementia that's different? But one thing that's always important to keep in mind is that there's overlap, whether it's in the parts of the brain that are affected, the proteins that are affected. And over time, if someone has one specific type of dementia, it can start to look like the others over time as more of the brain is affected. So, you can get language changes, behavioral changes, even in Alzheimer's disease. So there's some distinction, some overlap, and I think that's what can make this all confusing for patients and families.
When you talk about frontal temporal, I think about frontal lobe with people's personalities, and that you knew them as this one person, and now it looks like they're kind of turning into somebody else, which can really be frightening, particularly if it's a dramatic difference that the family has to go through a big adjustment, and I think needs psychological support in order to deal with that big change. I've seen that happen with some folks that I have known, and their spouses are so upset, saying, I don't think my husband's here anymore. And I say, I agree. The person that we knew and that you knew very well and just loved isn't here as we knew him before. But deep, deep, deep inside there, he's still your husband and you still love him. A girlfriend of mine visits her dad at a nursing home every Sunday, and he's been silent for now over 10 years, doesn't utter a word. And Thanksgiving weekend, she visited him on that Sunday and got frustrated. She told me, I just got frustrated because I thought I'd come here every Sunday. And I sit there and I talk to him, but I don't think he's hearing anything. I don't even know if he knows I'm here. And so she said, when I went there on Sunday, Thanksgiving weekend, I looked him in the face and I said, Dad, are you in there? And he spoke and said, I think so. Wow, that was certainly startling for her, but she said, I'm going to be right back there every Sunday. And I said, of course you are. Absolutely you are. Can we talk about genetics and what role that may play? What type of genetic testing for a mutation is available and who should be tested?
Genetics certainly plays a role. But I think we know that for most people who have dementia, genetics is not the entire explanation. In thinking about genetics, and Alzheimer's disease is the most common cause, I'll focus on that one mostly, that we do know with Alzheimer's disease, there are a few genes that are seen and implicated in families who have what's called early onset Alzheimer's or young onset Alzheimer's, which basically means that we see symptoms and functional impairment before the age of 65. And with those few genes, if you have the gene, you will develop Alzheimer's disease. But that is not the most common cause. That's pretty rare. Usually when people are asking about genetics and Alzheimer's disease, they're often thinking about later onset Alzheimer's dementia, right? That their parent had it in their 80s or 90s, and are they at risk? With late onset Alzheimer's disease, there's primarily one gene that's associated with risk of Alzheimer's disease. And it's getting more attention now with things like 23andMe, where you can get those results. It's specifically the ApoE4 gene. We all have ApoE. It comes in 3 different flavors, E2, E3, and E4. And E4 is the one that we see the Alzheimer's risk in. But what's interesting about ApoE4 is having the gene does not guarantee that you will have Alzheimer's. It increases your risk, so you're more likely to have it than someone who has 0 E4 genes. You can have 1 or 2. If you have 2, you're at higher risk, but even then, it does not guarantee that you will develop Alzheimer's. In general, I would say if someone is concerned about their genetic risk, the best bet really is to work with a genetic counselor and a geneticist, so that if you get tested, you can really put those results in the context of you and your family and your overall risk profile, which is more than just that gene. Because we certainly see people who do 23andMe or do some testing, and then they're so worried that they have Alzheimer's disease or that they're going to have it. And so being able to understand that it increases risk, it doesn't guarantee it, is important. For people who do have that very strong family history and its early onset, there too, it makes sense to work with a geneticist and a genetic counselor. But there, people can often map it out, right? That dad had it, grandma had it, where there's a very clear pattern versus one person in your family had it and they were 90. And again, I mentioned before, age is the biggest risk factor. So that's what I generally would recommend. And what we know about Alzheimer's and genetics, as I mentioned, there's other types of dementias. And with the other types, frontotemporal dementia is the other one where there's a lot of attention given to genetics. But even there, genetics explains some of the cases, but most cases are still sporadic, meaning that they were just random. And so even there, the recommendation is always work with a geneticist, work with a genetic counselor. And in some ways, you can map out how much of that genetic risk is there, but it's understandable that families feel anxious. My dad actually had a type of frontotemporal dementia, so I've thought about my family history. But for example, my uncle, who's also a physician, when I talked with him, he said, we have a huge extended family, and literally he is the only person who had it. So just that knowledge alone makes it less likely that we have a genetic cause. But that's where, if you're concerned, you can work with a geneticist. Usually they'll say if the person who has dementia or one person in your family that has dementia is alive, they'll usually test them first, actually, to see do they have the gene before going down through other people. And it's always important too to think about not just the implications for you, but other family members. Because if you're thinking of getting yourself tested, it actually has implications for your children, for your siblings. Right. And so it's a lot to think about. And I don't think people always give it the weight of thought or seriousness that we should when trying to get such information.
And because it's relatively easy to get, I tell patients, I compare it to a pregnancy test. It's real easy to do a pregnancy test in the privacy of your own home, but the ramifications of the results are profound. People will say, well, it's simple to do. I'm going to check. And they'll say, regarding this, what's simple to do? And I'm like, but the ramifications of the results can be huge. I have always wondered and worried if some people are being diagnosed who really don't have a form of dementia, but actually have hearing loss. If they can't hear, they're not able to answer questions correctly. They might even answer in the affirmative on anything that's asked of them, just nodding their head, because they have no idea what's been said to them, and they're too embarrassed to say, I couldn't hear you. I'm making an assumption that part of the evaluation of a patient also needs to include how good is their hearing. And of course, we know that there are some spouses who have selective hearing. We know that. But I do think it's an important point that I don't want someone assuming, oh, he obviously has, right, some form of dementia and has Alzheimer's, when maybe he needs hearing aids. With Medicare not covering hearing aids, it makes it that much more difficult to get the right resource into that patient's ears, because hearing aids can be incredibly expensive.
There's a couple of great points I think that your comment brings up. One is that when we make a diagnosis of dementia, actually part of that is ruling out other potential contributors to what looks like cognitive change. Hearing loss is definitely one of those, and hearing loss is actually associated with dementia. Yes, it could be the hearing loss entirely, but someone could have both, and it's important to try and tease that out. It also means ruling out medications that could be causing cognitive problems, ruling out depression. So it's really thinking about other medical, psychiatric, or sensory issues that could be contributing to feel comfortable saying, we think that this person has a neurodegenerative disease that's causing dementia that's independent of those other pieces. And to your point, some of those diagnoses, we find them hearing loss and it might be hard to address. I think that's where, of course, we've all looked positively over the past year when at least over-the-counter hearing aids became approved, that it's still not cheap, but it is certainly cheaper than paying for the fancy hearing aids. And it's something to start to address, an important symptom for people.
Is there anything that we can do proactively to prevent or to delay the onset?
Prevention, or what we can do proactively, actually has been a huge area of research and a growing area of research, really just because of how common dementia is and that we know the population is aging. The list of risk factors and things we can do is really growing by the month. One of the studies I look at commonly, there's lots of reviews, is that in 2020, there was a Lancet commission that looks at dementia treatment and prevention. And so they looked at research studies that have been done in the past, the strength of the data that we have. And in 2020, they found that there were 12 what they called modifiable risk factors that accounted for potentially up to 40% of dementias worldwide. So these are things that we can do something about. And that's why I was saying, right, it's not just genetics, it's not just age, there's other things that play into it. And in terms of that prevention, I think it really depends on your personal context and honestly, even where you are in your life, because we know that there's these risk factors over the life course. So in early life, that education that you get mentioned, right, that education and career matters. There's more and more research just on childhood trauma, adverse events in childhood, and what effect that might have on brain development and cognition over time. In midlife, we already talked about hearing loss. That was actually the biggest risk factor starting in midlife for dementia down the line. Some of the other risk factors that we hear a lot about are things like traumatic brain injury, excessive alcohol use, and in midlife, hypertension or high blood pressure and obesity are risk factors. And so if you think about those risk factors, those are all things that we can do something about. If we have hearing loss, we can treat it with a hearing aid. Traumatic brain injury, we can think about, right, strategies to reduce that risk, whether it's helmets, paying attention to personal safety. Hypertension, we can diagnose it, we can treat it. And then there are even late life risk factors. So again, even when you're over the age of 65, risk factors for developing dementia in the coming years, those are things like physical inactivity, social isolation, depression, smoking, diabetes, risk factors in late life. These are just the 12 risk factors that were named in 2020. I think there's lots of areas of ongoing research. So whether other medical conditions, whether insomnia or sleep disorders, sleep apnea, whether conditions like that might increase the risk down the line. And those, again, are all, I think, risk factors that we can act on. Unfortunately, for most of them, it's not just a pill. So when you think about physical inactivity, social isolation, it's a lot of kind of living a healthy, active lifestyle throughout your life, in midlife and in late life, really to preserve the brain as you age.
And keep your blood circulating. Get
yes,
some blood to your brain.
That's exactly when people will ask, will say, whatever is good for the heart is good for the brain. It's not something we always think about, but certainly as people worry more and more about aging and cognitive decline, I think it's more reason to really try to put into action those things that we know are good for us, but are so hard to do.
Absolutely. Let's talk a moment, because you said there isn't some magic pill to be able to take. There is a pill given by prescription for some Alzheimer's patients. And there's also commercials on television of direct marketing to consumers for pills that are supposed to improve people's memory. What's listed at the bottom of the screen on the television, you have to read like major fast. I actually recorded it so I could slow it down and see what it said. So while the voiceover on the commercial is saying this can dramatically improve your memory, yada, yada, and that research has proven that, if you read the bottom, it says there isn't any research that's proven this at all. And because people want hope, they'll go to a pharmacy and they'll pay a lot of money and they'll take these pills for which I have no idea what's in them. some have a placebo effect of, oh, yes, I think I'm doing better. But the reality of it is it isn't going to do anything. I don't want our listeners running off to their local pharmacy and saying, I want to stock up on this. Sadly, it's just a waste. The FDA doesn't regulate those kinds of things. So people think, well, the FDA said it was okay. No, they didn't. That's something that isn't regulated. But for the pill that has been prescribed in some cases for Alzheimer's, what percentage of patients would benefit from receiving that type of a actual prescription drug?
One, I would just echo what you said, which is that for some of the supplements or pills that we see advertised on TV that are not prescriptions, there's really not strong or consistent evidence that they're effective. And I will often tell people that, yes, you're better off using your money for other medications. Or, gosh, if someone is going to develop dementia, we know that it's an expensive disease, that care costs money, and you're better off saving that money for that support that will be needed. But as you mentioned, there are prescription medications for Alzheimer's disease. And we often use the older prescriptions for some other types of dementias, but there's differing evidence in other types of dementias. But there's two main classes of drugs that are FDA approved for the treatment of Alzheimer's disease. One class of drugs are called cholinesterase inhibitors. So they boost the amount of acetylcholine, a neurotransmitter in the brain, that there's less of it in people who have Alzheimer's disease. And there's a couple of drugs in that class that we use pretty commonly. We think of them, though, more as symptomatic medications. So they don't change what's happening, for example, with the amyloid and tau in the brain or the disease process, but they can help people feel better in terms of their memory, their thinking, confusion types of issues. So in that way, I almost think of it as Tylenol, or for example, or taking ibuprofen for pain. It may treat the pain. It might not be getting rid of the underlying issue. With those medicines, I would say we see that about 20 to 30% of patients or families will notice some benefit, often small, but it's noticeable to them, in which case we'll continue it. A lot of people, unfortunately, don't see a huge difference. There is a difference in studies compared to placebo, but how clinically meaningful that is, it's not always that noticeable, and people still decline over time. But we will, for example, and I know most of my colleagues in the memory clinic will use it for people who are early to middle stages of Alzheimer's dementia, if they're appropriate. And most people are, but we do look at things like, how is their heart rate? Because they can slow down the heart rate. It can cause GI side effects. It is associated with falls. And especially in my older patients, I'll look at how many other medicines are they taking, because there is that risk that, okay, could provide small benefit, but gosh, could we end up harming the person in the process, that they end up passing out from a slow heart rate or having really distressing GI symptoms? So that's the most commonly used class of drugs. And then for moderate to severe Alzheimer's disease, memantine is another FDA-approved drug that acts on a couple of neurotransmitters. That one, I would say it's better tolerated, but maybe it doesn't do quite as much in terms of actually having an effect. And it's similar, right? It's symptomatic treatment. So up until the past year and a half, all we've had available are these prescription medications that we use in a lot of people who have Alzheimer's, but not everybody. What can be challenging is that people are understandably wanting hope. And so often there's unrealistic expectations about what the medication can do. So I'm always careful to talk about that.
That is important. You don't want them to see this as a miracle pill.
Yeah.
That possibility is pretty slim.
You know, one thing I think that might be worth talking about, maybe as we're talking about medications, as I was talking about the pills that have been around actually for a while. Just in this past year, there has been a new FDA-approved IV medication for Alzheimer's disease. I'm not sure if you had heard about it yet or not.
No.
There has been a lot of news around it because, gosh, it has been a decade or more since we've had an FDA-approved treatment for Alzheimer's disease. So the two that have made it through the FDA, although there's more coming down the pipeline, are called aducanumab or lecanemab. Those are IV medications, so not pills, that are what we call monoclonal antibodies that are anti-amyloid antibodies. So what they do is they clear amyloid from the brain of people who have early stages of Alzheimer's disease. They've gotten a lot of attention, not just because they're new, but because there have been questions about their clinical efficacy, right? So how well do they work? From the studies that have been done, it's very clear that these drugs are really good at removing amyloid plaque from the brain. But what the controversy has been is, does that translate to changes clinically? And a lot of that has been because up till now, a lot of these anti-amyloid drugs have failed. So these were the first that worked. We know that having amyloid plaques on the brain is a hallmark or biomarker for Alzheimer's disease, but there's been a lot of controversy on, is it the cause or is it just on the pathway or a side product? And what we've seen with these drugs is that they don't entirely stop progression of cognitive or functional changes, but they might slow it. So the people receiving these IV medications compared to placebo have a little bit less decline over the 18 months of those studies in cognitive and functional changes, but it's a small difference. And so what's been controversial in the clinical and scientific communities is that change meaningful? Some people who are more worried about the side effects will say it's such a small change, it's similar to the pills that we have. Is it really worth it? The people who are in favor of it say it's a small change, but if amyloid is the cause, then compared to the pills, we're actually changing that cause of disease, removing it, and maybe over time that'll translate to a bigger change. But I think the biggest challenges with the medicine are, one, it's an IV, so it's not a pill you can take at home. It's either once a month or every 2 weeks you get an IV infusion. And the biggest concern has been the risk of side effects. So about a quarter of people receiving these drugs experience small bleeds or small areas of swelling in the brain. And so especially, right, we're thinking about oftentimes older adults who have other medical issues. That's a real concern. Most people who had that side effect don't notice it, but for some people, they end up in the hospital. There were reports of a few deaths, and the drugs are not cheap. It's new, it's exciting that there's new drug available, but how well they work and really how they play out in the real world outside of the clinical trials is something I think we're really going to be seeing it in the next year or two as people start to receive these new drugs for Alzheimer's.
Can you also share with our listeners about some of the other current research studies that are taking place at Johns Hopkins?
Gosh, I would say, especially in the area of Alzheimer's disease and dementia at Johns Hopkins, there's research really spanning the spectrum or gamut of what we care about, thinking about better understanding the causes and all the contributors to developing dementia, thinking about preventive strategies, how can we be proactive, and then certainly treatments that are targeting people who have the disease at the earliest stages, whether it's trying to slow progression or treat other troublesome symptoms that are common in dementia, like behavioral and neuropsychiatric symptoms. And then there's also studies looking at non-medication treatments, as well as just care delivery strategies. Research, I think, on hitting all fronts of dementia. We were talking about hearing loss. There's a big group studying hearing loss and cognitive decline in dementia here at Johns Hopkins. They published a really exciting shared worldwide study on actually treating people with hearing aids who have hearing loss to see, does it affect cognitive decline over time? And that study was fascinating. They took people who were cognitively healthy, so they don't have dementia, but they have hearing loss, and either had people use a hearing aid or had a healthy education control group. And what they found was that over 3 years, overall, there was actually no big difference in cognitive test scores or the change in cognitive test scores over time in the people who were wearing hearing aids versus not. But then when they looked at people who were actually at higher risk of developing dementia, for example, the women in the group, people who had other medical risk factors, people who were older, groups that we know are at higher risk of dementia, there they saw actually an almost 50% reduction in the rate of cognitive decline just over 3 years.
Wow.
And so that study has really been hailed as saying that, okay, at least from the study, we can see that people who are at high risk and have hearing loss, beyond just improving quality of life and hearing, those hearing aids might have benefit in cognitive decline. The study's ongoing to see, might there be an effect on the people who are at lower risk? Because with dementia, it really develops over years and decades. So one thing they thought was that it might be that 3 years wasn't enough to see a difference in people who aren't as high of a risk of dementia. So they're going to keep following these people over time to better understand the effect of hearing aids on developing dementia.
Let me also ask you about some of the neuropsychiatric symptoms and what is available from a treatment perspective. I've been hearing things regarding even music therapy.
Yeah, so this is actually in the areas of dementia that we have research at Johns Hopkins, I think looking at neuropsychiatric symptoms between our psychology groups, our geriatric psychiatry groups, there's just so much going on. And those are really, I think for people and families who are living with dementia, those neuropsychiatric symptoms, depression, apathy, agitation, not being able to sleep, are often the hardest parts of dementia to manage at home. There's a lot of studies looking at different treatments because they're troublesome symptoms. And the medications that we currently use have really mixed effectiveness and a lot of side effects. So there's a lot of interest in, gosh, can we find more effective, lower risk treatments? Some of that is medications. Some of that is not medications. So you mentioned specifically right now at Johns Hopkins, there's a study looking at just virtual music therapy interventions and how does that affect in people who have mild cognitive impairment or early stage dementia due to Alzheimer's? How does it affect not just their memory and their cognition, but for example, how does it affect anxiety to see if it reduces symptoms of anxiety? There's certainly studies that are looking beyond what we think of as non-pharmacologic, non-medication treatments of, again, looking at medications that are already out there for other purposes. So I've been helping one of my colleagues with a study that's looking at a medication called dronabinol for agitation in Alzheimer's. And dronabinol, in some ways, it's just a synthetic THC. Medical marijuana is getting a lot of attention. This is a synthetic, FDA regulated, already approved, for example, treatment of nausea with chemotherapy. But now we're looking at, does it reduce symptoms of agitation in people with Alzheimer's disease compared to a placebo? There are studies looking at trazodone. It's an antidepressant that we most often use for sleep to see in people who have mild cognitive impairment, does it improve sleep and memory, as well as looking at just changes over time. A lot of different studies targeting whether it's the cognitive symptoms, the neuropsychiatric symptoms, and prevention. So I think for people who are interested and willing, there are lots of options out there. I know some people are nervous about trying a drug in a clinical trial, but then we have these studies of interventions that are not medications that might be lower risk, but certainly have potential to be effective.
That's incredible. And I'm really pleased to see that research is not just happening at Hopkins. We know it's happening in many, many facilities. I think that it's working hard to get some of these symptoms managed because I cannot picture a family caregiver trying to deal with all of this with a loved one at home if they're expressing anger and they're not sleeping and good grief. I would probably already be diagnosing the family caregiver with clinical depression because he or she can't get away from it and needs help with this. I am a believer that family caregivers who are caregiving to someone with Alzheimer's does need respite periodically. They don't like to take time for themselves. They feel guilty doing that, but they need to recharge their batteries, arranging for someone else to be there or even having their loved one with this disease be in a safe facility for them to be able to go away and visit other relatives or just take a trip somewhere. I know of some people that just say, I just want to be home alone, which I think is very reasonable. Do you have any suggestions for individuals that are living with dementia and Alzheimer's, as well as their caregivers that are trying to fight the fight with them and for them?
There's so much to suggest, but I think one of the biggest things for me, if I'm, for example, making a new diagnosis for someone and their families usually with them in the clinic, it's really focusing on the present, preparing for the future because we know it's going to progress, but focusing on and living in the present. And in terms of preparing for the future, it's definitely important. I think this is an area a lot of people just don't know a lot. So it's important to learn more about what dementia means for that person now and also what it means down the road, but then really focusing on the things that the person is still able to do, not on the things that they're not able to do, but really maximizing their current abilities, focusing on just making memories now and just making the adjustments or adaptations that are needed to live better again in the moment. I know for our family and for lots of other families, that also just means putting together your care team or village. So the people who care about you, some of those might be medical folks, but certainly people in your family, in your community who can help support you now and also support you as the changes come. I also just suggest that people focus on the treatments and brain health strategies that they can put in place easily and not worry about trying to do everything and have we done everything everything that we can, and have we done it perfectly? Because I think you already mentioned the stress that caregivers are under, and oftentimes the person living with the disease and the caregiver are putting themselves under even more stress, trying to make sure that they've got the perfect diet, they're doing exactly the right exercise, and really just focusing on just doing our best in a way that's manageable, that's not increasing stress on the caregiver, that's not increasing stress on the person who's living with the disease. And really, for both of those people who are at the center of it, the person living with the disease and the caregiver, as much as they're able to, giving themselves grace and then giving each other grace, because everybody's in a situation that they didn't want to be in. And I think something that I've reflected on as my family's dementia journey had gone on is just finding the joy in the small moments and the connection together. You know, you mentioned your friend's experience with her parent, and just like really appreciating that one moment when it's there. And, you know, I'll just mention the reason I really encourage people, especially when they're getting diagnosed, it's often early or early middle stages. And I think when people hear the diagnosis, they just imagine worst case scenario, which is often that advanced or end stage disease where someone might not recognize their loved one, might not be able to speak, or is really dependent on others for daily activities. And in that worry, we're overlooking where the person is now, where they can still do a lot, where there's still a lot of living to do and a lot of memories to make. And so again, trying to focus on now and what do we need to do now? Yes, prepare for the future, but not living in that future. None of us can predict exactly what it will look like, how things might change and evolve over time.
One of my mantras is don't postpone joy. People will say, oh, we're going to go on a vacation to Disney World with the grandchildren 2 years from now. Life's unpredictable, right? So better to consider doing it sooner versus later so that everyone can enjoy their time in doing this. Absolutely. We talked about plaque in the brain, but we didn't talk about how does a doctor determine that a patient has plaque in the brain. So can you talk just a moment about what the tests are, what the imaging studies are that are done that signal, gee, I think that's what's going on here?
What's exciting is that's something that's actually literally changing as we speak. Historically, really making a diagnosis of dementia, and then often even the type of dementia. So what we call a clinical diagnosis. That meant that there wasn't a single test that we could use to say, this is it. It meant that we would rely on history. So what does the patient tell us? More often, it's what does the family or the people who know the patient well tell us? What are they noticing? Doing a good physical and cognitive exam to see what changes or abnormalities can we pick up. And then using clues from imaging, which is most often an MRI, to see are there old strokes in the brain? Is the brain more shrunken than we would expect? And in certain areas, is it the frontal lobe? Is it the memory centers? Putting that all together to say, here's what we think is going on. And part of that is ruling out the other things, the hearing loss, depression, other things like that. But really evolving as we speak are those other tools that we can use. Specifically for Alzheimer's disease, we do have ways now that we can test for that amyloid plaque. Specifically, there's specialized scans called amyloid PET CT scans, where we can actually look at how much amyloid plaque is in there. It's actually, interestingly, those tests have been around for more than a decade. The FDA approved it more than a decade ago, but Medicare up until now did not pay for the scan. So we weren't usually doing it. And the reason Medicare didn't pay for it is they said, yes, it can make the diagnosis, but we don't have great treatment. So is it going to change what we do? Now that there's new drugs available that clear amyloid, now Medicare is starting to cover it on a case-by-case basis because, right, if I'm going to treat someone with an IV medication that clears amyloid, I need to know that there's amyloid there. Before these recent months, we would have to often do a lumbar puncture, so a spinal tap, because the other way you can test for amyloid and actually test for that tau protein. So the other protein that's abnormal in Alzheimer's disease was in the spinal fluid. But as you can imagine, people aren't as excited to undergo a spinal tap as they might be to just, oh, I'm going to have a specialized imaging scan. And I think even in the coming years, coming decade, we're going to see a lot more coming. Right now, there's tau imaging. That's really just in the research world. I can't order it on a patient, but I think as we learn more about how well those function, how well those help us make a diagnosis, they might become available. The other thing that's starting to become available, not, I would say, in prime time yet, is actually blood tests to look for amyloid. So again, trying to come up with cheaper, easier ways to make a more specific diagnosis. And I would say a lot of those specialized tests right now are probably still living in specialty centers. But for example, as blood-based markers become available, they might start making their way, for example, to primary care where they're a little bit more accessible. But I think it's important to interpret those results in the right context. And the reason I say that is, for example, with amyloid, we know that at age 80 and over, 30 to 40% of just normal, healthy people will have amyloid. And that doesn't mean they have Alzheimer's. And that's where it's important to put it in the context of the person, their health, their history as we interpret the results. But, I think exciting times in our field when it comes to diagnostics and being able to give families more specific information than we could have before.
Excellent. Excellent. Well, it's exciting to know that there's a lot happening today and a lot more coming on the horizon for us to better understand this and be able to develop methods to cope with it as well as symptom management for it. So I want to thank you ever so much, Dr. Amjad, and also thank everyone that's listening to us today. We're in the new year, 2024. We certainly do hope that it's a healthy as well as a happy new year. To receive additional information about our other women's health issues, please visit the A Woman's Journey website at hopkinsmedicine.org/A Woman's Journey to sign up for our monthly e-letter, read about upcoming podcasts, to sign up for our upcoming free Conversations That Matter webcasts, and learn about our live programs. And thank you for listening, and I hope that you will join us next month for another educational and informative podcast featuring another Johns Hopkins Medicine expert.
Thank you for listening to A Woman's Journey podcast. Join me, Kelly Gear-Ripken, your host, Lily Shockney, and a variety of Johns Hopkins experts on the first Thursday of each month to learn about medical advances in women's health. A Woman's Journey acknowledges unrestricted educational support for our podcast, Healthy Insights That Matter from Astellas. For more information about A Woman's Journey's virtual programs occurring throughout the year and our monthly webcasts and podcasts, visit our website, hopkinsmedicine.org/A Woman's Journey. Like us on Facebook and Twitter, and visit our website at hopkinsmedicine.org/A Woman's Journey. Until next time, stay well.